The Conquer Worry Show, episode number 23. Welcome to the Conquer Worry Show, the show dedicated to helping people who struggle with their minds. If you are looking for stories of resilience, if you are looking for inspiration, or you simply want to conquer worry, this is the show for you.
Welcome to this special episode of the Conquer Worry Show. I am your host, Jay Coulter, and today I have Dr. Maura Rynn with us. Dr. Rynn works at the Department of Psychiatry at Columbia University, and as of this past January, she became the director of the Division of Child and Adolescent Psychiatry. She is also the medical director of the Columbia University Clinic for Anxiety and Related Disorders, as well as the director of the Children's Day Unit and the Child and Adolescent Psychiatry Evaluation Services. Her specialties are pediatric anxiety disorders and pediatric mood disorders. Dr. Rynn, thanks for joining us on the Conquer Worry Show.
Thank you for having me.
First, tell us how you would describe OCD to an adult.
So when I describe it to an adult, I describe how this anxiety is characterized by these thoughts that one can have that are very intrusive, can make someone feel very uncomfortable. They can also be images or impulses to do certain things like obsessions. And these things can be very repetitive. They can also be repetitive mental acts that one does. And there can also be repetitive behavioral acts, which are also called compulsions. Many of the clinical and the comorbid features, both for children and adolescents, are very similar to adults with OCD. So having these very repetitive thoughts or ideas that increases one's anxiety and makes you feel uncomfortable, and that they can often be linked to an actual behavior that someone does in order to release that anxiety, and with the hopes that it will actually stop some of the images or thoughts that are very distressing to that person.
That's interesting. Images. Could you give us an example of that?
Well, some adults can experience an image that's very distressing, like it could be that they may be, for example, in their car driving. They stop at a red light, and somebody has come in front of their car to cross the street, and somehow they start thinking and seeing that they actually hit the person, even though in reality they haven't hit the person. And in their core, they know they haven't hit the person, but the light turns green, they keep on driving, and they keep having this image playing over in their mind that's very distracting, that in fact they thought that they hit the person, and they may have really harmed the person, and see actually images that are distressing and harming the person. Some young adolescents have said to me, they have a thought, they might be at the dinner table, they see a knife, and they have this repetitive image of that they could potentially harm somebody with the dinner knife, or with to themselves, and sort of have these images that play over and over again. And these images can be in a wide range of areas. It can be things of harming oneself, harming somebody else, or images that are sexual in content that make them feel very uncomfortable, and then may lead to another kind of a behavior with the hope that it might stop those images.
That's interesting. So you described OCD as you would describe it to an adult. Tell us how you would describe it to a child.
So for children, we talk in similar terms, but try to make the language simpler, but describing, are there thoughts that you're having that are repeating themselves? And I'll sometimes say to some kids something like playing a tape over and over again, or something that you might listen on your iPod over and over again, that you can't stop, that's making you really feel uncomfortable, or you feel is happening so much that it keeps you from being able to do other things that you need to get done. Does it increase your feeling of feeling nervous or uncomfortable that you need to do something else in order to stop it? And a lot of times, children and adolescents will say, it's so funny that you say this. I have this sentence that I can't get out of my head. It keeps going on and on and on. It might have to do with something I have to say so many times in order to make sure my mom is safe if she goes out of the house, or something that I have to say in order to make sure that I'm safe so many times. And if I don't do it a certain number of times, I feel very uncomfortable. I feel bad. I feel like something might happen, and I might actually have to go check on that person that I'm worried about, or check that the doors are locked. And that, generally children can understand. Those children that are experiencing it can relate to that when they hear that. So the repetitive nature of thoughts and ideas that are making them uncomfortable, that they can't get out of their head, that's kind of stuck on their minds. So kids will say, "Yeah, it's just stuck in there. It's something that's just won't leave me alone, and it's giving me trouble falling asleep. I'm having trouble concentrating in class. I'm having trouble listening to what my parents want me to do because I have these constant thoughts that are upsetting me, and then I feel like I can't stop them."
So, Dr. Rynn, do those thoughts last for a certain period of time, like a couple weeks, or is somebody struggling having those thoughts for 6 months, a year?
It's variable. It can be constant, and it can be for an ongoing year or longer. Sometimes the symptoms of OCD can change over time, so there can be a certain combination of thoughts that a young person may be struggling with, and then they might change over time to different areas of their life. Sometimes a child might be experiencing some concerns about getting contaminated with germs, for example, and have various thoughts and ideas like, if I sit next to this person, they're going to contaminate me, or they look like they have a runny nose, they're coughing, I think I'm going to get sick, I better go to the bathroom, I better wash my hands so many times in order to make sure that I'm not going to catch that cold. And so to have this repetitive ritual to the point where they might constantly ask the teacher to move their chair. They can't sit in the same seat, or they can't sit next to a student that they may be concerned is sick or might get them sick, and sort of starts this thought process. For that some young person, that fear of contamination might shift into something, totally different. It might shift into some religious concerns, thinking about God, feeling that they have to pray a certain way or pray so many times on a particular day because of some concern of something bad happening. And it could be that some of the concerns with the contamination actually goes away, and they're actually in another area of focusing on these kinds of other types of symptoms. And, I've had parents say to me, sometimes when they're trying to help their child that has OCD, it feels like whack-a-mole. You kind of get we hit one away, something else seems to pop up. And that can change and evolve over time as the child and adolescent gets older. And it can relate to events and things that are going on in the young person's life that, may trigger a change in a course in the symptoms. That's really related to things that are going on in the environment, or maybe new stressors that are happening in their life, or new developmental things that they're trying to do, like dating or being more social, might actually trigger a change in these obsessional thoughts and these repetitive behaviors.
Well, generally, what ages will be encompassed with pediatric psychiatry?
So in general, for pediatric psychiatry, you can, in general, for anxiety disorders, generally you can see children as young as 3, but more on, average, it's starting at 4 right up into young adulthood. There is an area of pediatric psychiatry that starts prior to age 4, sort of works with toddlers and even infant psychiatry. So that's another whole field that has grown quite significantly over the past 10 years, with some evidence that you can see some evidence of anxiety and depression that early on. But someone like myself in my work who's doing, treatment with young people with anxiety, generally children are coming to our clinic as young as 4. And I would say on average, it's really between 8 and 14 for a peak of anxiety symptoms that are really troubling and getting in the way for that young person.
Okay, well, let's shift gears just a little bit and talk about what could cause OCD.
So there's been various studies, imaging studies that have looked at the brain, to look at the structure of the brain, to also look how the brain is functioning, to suggest that OCD is associated with abnormal functioning of certain brain circuits that include areas called the orbitofrontal cortex, the striatum, and the thalamus. So it's felt that there's a dysfunction in that neurocircuitry leading to the OCD symptoms. Also because there's a class of medications called the serotonin reuptake inhibitors, which is a class of antidepressants, have been found to successfully treat obsessive-compulsive disorder, that there may be, it infers that there may be serotonergic abnormalities that may be causing these symptoms, and that this may lie in this neurocircuitry. There's other evidence that suggests through animal and human studies that implicate another neurotransmitter system, the glutamatergic system in OCD. And this is based on some genetic finding an association between OCD and genes that are related to the glutamate system. And they've also seen that in animal models when they interfere with the transmission of glutamate in these particular brain circuits called the cortical striatal circuits, by deleting production of certain proteins, that you can lead to OCD-like behaviors in mice. So there has been a new area of looking at glutamate modulating medications as well as for OCD. And there's active research looking at better understanding the underlying neurocircuitry for OCD, because it does seem children, adolescents, and adults can have different response patterns to the treatments that we have available. Some young people will do very well with some of the first-line treatments for OCD, and others don't. And so it suggests that there may be other pathways involved for seeing this differential response. And so there's a lot of active research to try to understand the neurocircuitry better so that one could develop newer treatments, be psychotherapy or medication treatment, to target the certain areas of the brain.
What are some of the signs and symptoms of OCD? And then specifically, if you could also address that in children.
In terms of how children present?
Yeah.
Okay. So some of the common signs and symptoms are these obsessions, or these repetitive thoughts or ideas that I was describing earlier. And some of the most common for children are a fear of contamination. So are they going to catch something? Is something dirty? Is something stuck on their hands? Will they be able to get it off their hands, or will somebody be able to get them ill? There's also the fear of what's going to happen in the future, what their fate is. Another area that I hadn't mentioned earlier is what we call symmetry. So feeling like things have to be balanced in a certain way. So some young people will feel like if they touch one side of their face, they feel really compelled that they have to touch the other side of their face, and that it has to be symmetrical. Or if they raise one hand, the other hand needs to be raised. Other types of compulsions or repetitive behaviors that you can see in children and adolescents that are common are cleaning. So if you have that obsessional worry that you may be contaminated, the behavior that's often linked with that to try to neutralize that worry or get rid of that worry is cleaning, so doing continuous cleaning. So there are some young people that may really feel that their body is contaminated by the end of the day, and may have a very extensive ritual in terms of how they clean themselves at night, and needing to do it multiple times. And it could take hours of the night, or they have to get up very, very early in the morning in order to complete the rituals of their cleaning. There's also young people commonly can suffer from repeating, so having to repeat maybe things in their head that people are saying, or repeating things, sort of lucky numbers or certain sentences, or their sentences have to have certain words in them, and so they have to repeat it. Unless they do it exactly right, they have to do it over again. Or it could be repeating of counting things. So, it could be a child's got a collection of toys, stuffed animals, and feels like they have to count a certain way to make sure all those stuffed animals are, and so they do it in a certain way, and that can lead to repetitive behaviors. There can also be frequent with kids sort of checking things, so making sure that things are safe, are the windows locked, are the doors locked, checking of the lights, or having to turn the lights on and off a certain number of times before they can actually feel okay about going to bed, or checking with their parents in their bedroom a certain number of times. And some parents can find themselves involved in some very involved rituals at night, trying to get their child to bed because the child may be having safety concerns, and there's all sorts of checking that has to occur in the room, and some of the rituals may involve the parent doing some of the checking with them before the child can feel comfortable with going to sleep. And some children have milder versions of this, and some children can have pretty extensive involved behaviors that can keep the whole family up until for several hours or even half the night, depending upon how involved it is.
All right, that gives me a little bit of clarity, because earlier when you mentioned that children as young as 4 can be diagnosed with this, having a 5-year-old daughter, I don't know that until you explained it that way, I'd be able to tell the difference if she was struggling with some of the issues as you described them for adults, counting her Barbie dolls or putting them a certain way.
Right.
It sounds like there's a clear, distinct challenge in the child's mind that a parent would be able to see. There isn't a gray area.
Right. You bring up a really important point, though, which is that at that younger age, particularly, under 12, and the very young, like 4 or 5, they may not communicate, and there's a lot of discussion in the field about whether, in fact, they are having the sort of thought part of OCD or the obsessions, and whether or not early on in childhood you're just seeing more of these repetitive behaviors that are not necessarily that they're able to identify initially that's linked to any kind of anxiety or repetitive worry or sort of repetitive image, and that the child may not, some people say, well, they may not be aware and that it's there in some format, and it's not until they're more verbal and cognitively mature that they can actually articulate it, and others will say, well, no, these behaviors start first, and what the parent might notice is a repetitive behavior that's hard to interfere. It's hard to get the child to stop. The child seems driven to have to do it. It's really, and I think the key thing with all of this is that it's impairing, that the parent really senses that it is getting in the way for the child to do things that are really developmentally, that the child should be able to engage and to be able to do. So if it's preventing the child to be able to participate in to play dates or getting into school, or if the teacher's calling the parent that the child is really is having a lot of requests to go to the bathroom, because of having to feel that something's, on their hands, and they have this, desire and need to actually have to wash their hands. Or, I've had children very worried, constantly fearful that they may actually have an accident, even though they never had, but they feel like they have to repetitively go to the bathroom and empty their bladder just for this fear that they could have an accident. Things like that, where it's really clear it's something that they're struggling with, and that the adults around them are noticing it. And it's not only the parents, but there are other adults in the child's life that are identifying that this is becoming apparent. And some children, as I mentioned, who have some of the symmetry problem might actually engage that around their peers. So if they find, some children may start touching and tapping up other peers in a certain way, and it has to be even or has to be a certain number of times, let's say when they're lining up to go to the lunchroom. And the teacher may notice that, and other kids may start complaining, like, hey, this child is constantly doing this sort of pattern on my back, and, this is making me uncomfortable, and the parents may get feedback that way. So I think early on it is noticing the behaviors, noticing if their child is really focused on certain types of things that they have to do before they can get out the door to go to someplace or to get to school, or they're getting delayed because of these. The child gets so upset if the parent tries to interfere with these behaviors. And it can be very confusing for the parent. They may not know, may not even realize that they've stumbled into interrupting a child's repetitive behavioral ritual, and all of a sudden see this child that's extremely upset, having a terrible temper tantrum, maybe hitting, maybe screaming, because the parent inadvertently has interfered with the behaviors that they're doing, and that may start giving them a clue that this is something above and beyond. When you're working with toddlers can go through a phase of, this feels sticky, this is icky, I don't like the feeling of this pillowcase, and I'll often get parents who have had a family member who's had a compulsive disorder and start seeing that in the toddler and say, what, I'm really concerned, my toddler is already showing something here, because they're a little more heightened to it and more aware. But in fact, this can often be a very normal part of the stage of development, right? So a lot of children will feel a little uncomfortable the first time they feel grass, or, they're on gravel, or, sticky surfaces. Kids can go through these various phases, or they don't like how these socks feel, or these type of underwear, I don't like the feeling of this cloth. You can see that at different points, particularly early in childhood, but in generally, it resolves. It shouldn't really interfere with the child being able to get dressed, to get out the door, to do the things that they need to do.
What a challenge for the parents, I tell you.
Yeah.
So this kind of probably encompasses some of what we've already talked about, but for the listeners who are listening because they have a child who's been diagnosed with OCD, there might be some utility in walking through the diagnosis model from the Diagnostic and Statistical Manual of Mental Disorders. They don't make it easy in your profession, do they?
No. So these words, and I'm sure, and I apologize to the listeners, I'm sure some of there's jargon. I'm trying to avoid jargon as well, but even for us in this field, the jargon can be very overwhelming. So I mean, just to sort of make it very basic, for the diagnosis of OCD, the young person or child needs to either have what I was describing before, these obsessions, so these constant ritualized, these ideas that are repetitive and distressing. They can also have compulsion. So the idea may lead to a compulsion that for a brief period of time makes that person feel better. So I think there's something on my hand. I think this is sticky. It doesn't feel good. I have to go wash, and they wash. And for a brief period of time, they wash their hands. With that behavior, they feel better for a little while, but then the anxiety starts building up again that, I think something's on my hand, and the parent may say, no, there's nothing on your hand, you just watched. No, I definitely think there's something on my hand, and it starts again, and the child feels compelled to then wash their hands. So it's a combination of the obsession of worrying that there's something on my hand or something that's disgusting on my hand, and then the compulsion or the behavior to try to get rid of that. The young person, one of the hard things that really can be hard for parents, that the young person may or may not realize that these obsessions or compulsions are excessive or unreasonable. Some do. Some realize and will say, yes, I know this doesn't make any sense, but I just can't stop myself. And other, particularly for adolescents, may say, I don't see anything wrong with this. There's nothing wrong that, I need to wash this way, or that I need rubbing alcohol and I need multiple bottles of it to clean my skin, in order to feel better. Like, that's perfectly fine. I'm trying to be safe. And they may not be able to, they won't, often respond to sort of, reasoning around that. The other thing with both the obsessions and the compulsions, they need to be significantly time-consuming. So they are taking up several hours in the day, and which then is leading to that young person to not be able to get through their daily routine, or to be able to be social for what would be appropriate for their age, or in the case of adults, of course, getting to work and being able to function at work. So these are things that both the compulsions or the obsessions are recurrent, it's persistent. For the thoughts, they're unwelcome thoughts or impulses or images. They're intrusive, and they really cause one to feel really unhappy, uncomfortable, and a lot of distress. And some, young people will describe trying to ignore these thoughts, trying to suppress them, but feeling like it's really, really challenging to do that. And some young people will say, I don't even try anymore to suppress it. I just give in to it. It's just too uncomfortable, and I try to do these behaviors to see if it'll get rid of it. And the behaviors are really, young person, children will describe it as well, feeling very driven to do it, these repetitive acts of hand washing. And there can also be, as I mentioned before, what we call repetitive mental acts. And those can be harder to identify for a parent to see that, but these are sort of these mental rituals that the child may be doing internally, thinking about, like I mentioned before, whether it's certain numbers that they have to repeat, or certain sentences, or certain words, or, worrying about how many, there's odd or even number of words and sentences as they're speaking. There can be some very elaborate mental rituals as well that can sort of fit into this criteria. For the compulsions, you see that the individual is trying to neutralize the obsessions with some other kind of thought or action, and these are in the hope to sort of prevent distress. But they generally can be excessive and not necessarily, realistically related to the problem that the young person is hoping that they'll fix.
Okay, well, let's talk about treatment options for a minute. What are the frontline treatments for OCD?
So the two main frontline, what we like to call frontline treatments, are medication. So as I mentioned earlier, the class of antidepressants, the serotonin reuptake inhibitors, have been found to provide effective treatment. And those medications are considered the serotonin uptake inhibitor. So one example is Prozac. Prozac is probably a common antidepressant that are familiar to most people. It has the Food and Drug Administration's approval for the treatment of pediatric obsessive compulsive disorder. And, there's a general dose range that physicians will start with, sort of a low dose, and then slowly increase it until they have maximized it, provided that it's well tolerated by the child or adolescent, and they are seeing a response of improvement. And there's several of these. So Prozac, I mentioned, is one, which is also called fluoxetine. The other is Luvox or fluvoxamine, Paxil, paroxetine, Zoloft, which is also called sertraline. So there's medication, but then there's also cognitive behavioral therapy, a form of psychotherapy, talk therapy, which involves two things that we call, which are exposure and response therapy. So this is an approach that tries to address those upsetting ideas, upsetting thoughts, and then these behaviors that really are maladaptive behaviors to try to, that are in reaction to this distorted thinking patterns. And so cognitive behavioral therapy really tries to identify these patterns, and using various goal-oriented and very systematic procedures to try to get the person to neutralize them. And this involves the patient or, a therapist working with a young person to expose him or herself to the very things that they're feeling fearful of with the therapist, and also exposing him or her to imagine the consequences of what he or she fears will happen if they don't engage in those compulsions. So if you were not to wash your hands, what would actually happen to you? What is the worst fear that the young person is imagining that will happen? So I'm giving this in a very condensed form. It's generally a 16-week treatment process. Parents really want to find a skilled therapist that's really trained in doing cognitive behavioral therapy with exposure and response prevention. They really want to ask the therapist, do they do exposure and response prevention, and have they had supervised training and experience with working specifically with children and adolescents who have OCD. I'm, in my area of work, I'm what they call a psychopharmacologist. My expertise is in the medications. I have the fortunate opportunity to work with very talented colleagues who are trained in cognitive behavioral therapy, and I certainly have seen them work, but I would never even pretend, even though I've been around them and have heard them lecture and teach on it constantly, and have worked on some very, preliminary work with families when I'm working with my colleagues that have the expertise in this. But I would not call myself someone that can provide this treatment, because you really need to have specialty training to do that. And I feel that, unfortunately, for parents, they don't know to ask that and to really carefully assess their options of clinicians to make sure they're getting somebody who's well trained in this area. We have a study that was completed in the field of child and adolescent psychiatry. It was called the Pediatric OCD Treatment Study, which it looked at comparing children and adolescents receiving either the medication alone, and the medication in this study happened to be the medication Zoloft, also called sertraline, which was picked mainly as a class of an antidepressant, not because there was something special about that medication, but just as a representative of this medication. And they looked at that as compared to children that got cognitive behavioral therapy alone and those that got cognitive behavioral therapy alone and medication combined. So there were three different groups. So children got what we call randomized, like a flip of a coin, like heads or tails. They either got the medication Zoloft alone, or they got the cognitive behavioral therapy alone, or they got the CBT, cognitive behavioral therapy, with the medication alone. There was more an improved response for those children that got the combination treatment, the cognitive behavioral therapy treatment and the medication treatment. However, also the children that received medication alone and cognitive behavioral therapy treatment did better to what we call a comparison, which is a placebo, so something that doesn't have any active ingredients. So there was a group of children that actually got a pill that had no active treatment in it, and they also didn't get the psychotherapy. So all three of the treatments worked well, and all those children that got one of those active treatments got better, but the children that had the higher response were those that received the combination of medication and cognitive behavioral therapy. So generally, our recommendation, it really, a lot of times it depends on your access to the right treatment provider. So if someone was to say, I'm living in a place that really doesn't have access to someone who is considered, completely trained in pediatric OCD, they have some cognitive behavioral therapy skills, one might recommend, well, you want to do that cognitive behavioral therapy and get the best that you can, and potentially consider combining it with medication treatment. If someone has access to a really well-trained cognitive behavioral therapist, it's perfectly fine to say, I'm not comfortable with starting with a medication for my child. I really would like to try first this specialized form of psychotherapy, and that can be quite effective. And of course, a lot will depend on what the child or the adolescent is comfortable with, and what the family is comfortable with, and their ability to access those kinds of treatments.
Those are a lot of decisions for a parent who's probably overwhelmed anyway with the OCD diagnosis.
Right.
Who would quarterback that from the medical professional standpoint? And by that, I mean head down, to help choose which path to head down, if not both.
Right. So, I think a lot of families will turn to their pediatrician. And, some pediatricians are very well equipped to be able to have some of these conversations and should hopefully know in the community what the resources are, and then make the recommendation to at least, let's start with this professional, and it could be a psychologist, and get a consultation from that person. The pediatrician can help the parents assess that it seems like the behaviors are really very, or that the impairment is so severe that it might make sense to start with a child psychiatrist to get a sense from a child psychiatrist's perspective, does it seem like the symptoms have reached a certain severity in order to warrant starting medication treatment. And it is very confusing because there's a lot of different factors that a clinician will think about in terms of prescribing the medication first or doing the combination of the medication and the cognitive behavioral therapy. I think the best thing for parents to do is to first start with their pediatrician to get some advice, and then to get their recommendation of who are the best mental health professionals in their community can steer the parents really well. And the parents should ask a lot of questions to be sure that the clinician that they're working with has had experience in working with children with the diagnosis of OCD. And to make sure that they have treated other children, whether it be for medication or for psychotherapy.
So what happens if the child is left undiagnosed?
Well, depending upon the severity of the symptoms, I have had experience of children saying to me, I had this early on, I was able to ignore it, I just, I've had kids literally say, I worked through it and I was fine for many years, but now it's come back, and it's come back to the point that I really can't manage it anymore, and I need help. And that's the thing that can be confusing with OCD. It can change over time, it can come, it can go. A lot of young people have very different experiences with it. But for someone who has persistent, ongoing symptoms of OCD that are really, taking up time of their day, distracting them from what they want to be doing, need to get doing, it can lead to a progression of not being able to complete school, be able to finish the things the young person wants to do. It can interfere with relationships, friendships, being able to maintain friendships. In some very severe cases, some young people progress to the point they don't want to leave their home, depending on what the their fears are or what their worries are. If they start beginning that things all around them are contaminated. I've worked with some young people who really can't, they get to the point that they're unable to leave the home, or the parents are unable to get the young person to, it can get to a point where the parents are struggling getting the child to get out of their bedroom. Or so they not to keep engaging the rituals, can't get them to school. So it can have a huge impact in terms of long-term outcomes and the ability for that young person to function as an adult. The World Health Organization has identified OCD as a leading cause of illness-related disability. So when it's untreated and it's really causing impairment and it can lead to significant difficulties for the young person as they go into adulthood. And it's very sad as a clinician when you meet an adult who's in their 30s or 40s and says, for whatever reason, the family and that person were not able to get access to a treatment or the right treatment or treatment that would help them, and they're to the point in their life where they're not engaged in work that they would like to be engaged, or they would like to have relationships with someone, get married, have friends, but they're completely limited by their OCD and have not been able to achieve the things that they would like to achieve in their life, and now they're at 30 and 40 coming in, or sometimes even certainly even later in life coming in and asking for help, and they have missed all this time period of important events one goes through during that time period, and it's hard to get back those events once that time has passed.
That's a great lead into my next question. So say the child is diagnosed, they go through whichever treatment path is best for them. Are there any education and career paths that tend to lead to better outcomes for folks who struggle with OCD?
I think the most important thing, I think any child with OCD can go on any career path that they want to and achieve any educational path that they want. I think the main focus is getting them the right treatment. And getting them engaged with the right treatment, getting access to the right treatment. I think, I often work with families in thinking about the right types of schools. I think all careers are open and there are all possibilities for the young person to consider whatever they want to be, but it may be looking for the right college setting or university that has some additional supports. A young person may be doing very well in their treatment for OCD, and there's maybe, for example, say they're seeing their cognitive behavioral therapist once a month for what we call booster sessions, and they're progressing to the point they're even doing less. Moving on to college can be a stressful experience. So the young person and parents just being aware that during stressful periods of time, there can be a relapse of one's symptoms. And this is true of anything one could be struggling with, depression, other types of anxiety, new changes in the environment, and which can be very positive and exciting, good changes, can lead to a relapse in symptoms. And so that my biggest focus on working with young people with OCD transitioning to college and to their first job is just to be very aware of that and to be prepared to start engaging in the treatment that has helped them, has worked for them, if they're starting to see a relapse in symptoms, and to really identify resources in the new town or city or new school that they're going to be at, to be very prepared to be able to get to reach out to start getting assistance if they should need it, and keeping in contact with their treatment provider. But I think there's no area that I think there's anything that the young person wants to do and be is all possible. Even if you've had an anxiety problem like OCD.
Well, I hope any of our parent listeners who have been sitting with us for the past 30 minutes, and if you're starting to feel overwhelmed, I hope you take away what Dr. Rynn just said, that any education or career path option is open with treatment. And to me, that seems the biggest takeaway so far in this interview.
Yeah, absolutely. And we do have really good treatments, as I mentioned, medication treatment, cognitive behavioral therapy, the combination of the two. It's just getting access to that treatment, making sure you're having the right team in place, and I have parents to really advocate. And I've had parents say, well, I never thought to ask about whether they were trained, or I felt uncomfortable asking them about their credentials. They should definitely ask those questions. Or the parent said I was uncomfortable. They were choosing a medication that I had never heard of before. When I did all my web searches, well, ask why. Why is this particular medication if it's not one that they realize it's been used for OCD? That is one thing in my experience. I'm finding that a lot of children with OCD are not getting prescribed the first-line medications that we know really can be effective.
Okay. Well, can you walk our listeners through what a typical experience would be like for someone who comes to Columbia University and your department for help?
So sure. So we have a couple of clinic options. We have a outpatient clinic treatment program that is in downtown New York at Columbus Circle called the Q Card Clinic. And if you Google CUCARD, that will come right up. And that's an outpatient treatment clinic where one could come in for an assessment and evaluation, and it would be a very detailed interview. The first few sessions are very detailed, probably about 2 to 3 hours, where they're getting a real sense of what the issues are, the problems. Both the child and the parents get interviewed separately and then together to make sure that we're making an accurate diagnosis. And the results of those assessments are discussed with the parent and child. And then a treatment program is designed with the child and the parents' input. And, additional things will be looked at in terms of there's learning disabilities, if there's other additional issues like depression or problems with attention. All of those things will be addressed and sort of looking at how that's contributing to the overall difficulties for the young person. The other program we have is called the Pediatric Anxiety and Mood Research Clinic at Columbia, where we are actually doing research treatment, and we're looking at novel medication treatment for young people who have not responded completely to their antidepressant treatment. So we are looking at an antibiotic, minocycline, which is a medication that is approved for children for infections and acne down to the age of 8. And we're looking at minocycline as an additional treatment to the child's antidepressant to see if that provides more of effective relief. And this is based on some preliminary data that we have and some hypotheses that minocycline may actually provide neuroprotective effects by changing the uptake of glutamate, which is one of those neurotransmitters that I had talked about earlier that we think might be contributing to the development of OCD, and that minocycline changes might potentially modulate these glutamate levels. But we don't know. So we're doing a research study to examine that to see if, in fact, minocycline as an add-on treatment to the antidepressant provides any relief in the OCD symptoms. So that's a present program we have. And again, it's very similar to our regular outpatient clinic, except it's a research program. Again, you get a very detailed assessment evaluation. Parents are interviewed separately, child brought together with this very detailed process, looking at the extensive history in terms of the medical history and so forth, and then a treatment recommendation is made to the family, and one of it might be not to even participate in our program. We may have other recommendations for the family, particularly if we don't think we're the right fit, because we really do ultimately want to help young people, children and adolescents feel better and help their families get onto a path that feels helpful and supported.
Is there those are fantastic programs. Is there anything about those programs or anything going on in any of your departments that I didn't ask you about that our listeners might benefit from hearing about?
Well, we actually do have an extensive array across mental health disorders that children may suffer with, from treatment of ADHD and studies, looking at different treatments with colleagues that I have at the of our faculty, other faculty looking at Tourette's, mood disorders, psychotherapy research. I mean, we actually have a whole range of program opportunities if one was to check out our website.
Great. Well, we'll have links to your website, all the programs that you talked about on this show in our show notes. Dr. Rynn, thank you so much for coming on the Conquer Worry Show.
Thank you for having me.
You're an invaluable resource for folks who are getting that OCD diagnosis, and you and anybody from your staff are welcome back on the show anytime.
Oh, thank you so much. Thanks so much for having me. Take care.
Thanks for listening to this episode of the Conquer Worry Show. For additional resources, please visit us at conquerworry.org. We can also be found on social media. Connect with us on Twitter at twitter.com/conquerworry or on Facebook at facebook.com/conquerworry. And new episodes can be found on YouTube at youtube.com/conquerworryshow.